So I'd like to thank everybody for being here this afternoon, which is wonderful. And we have to start with the housekeeping. So we're not expecting a fire practice. If the alarm sounds, can all present leave the building as quickly as possible by way of the nearest exit? And the designated assembly point is in the public square in front of Cast, beyond the fountain and away from the civic office. If there's anybody with mobility issues, please wait in the refuge area at the top of the stairs where the emergency evacuation lift is located, and use the intercom situated to the left-hand side of the lift doors to call for assistance. No roll call will be undertaken. Mobile phones, please have them on silent or switched off, please. This meeting will be audio-visually recorded and will be available to view on the Council's website and YouTube channel. Can I ask all those present to use the microphones to ensure the audio can be captured, and then remember to switch it off when you've finished speaking. Any members of the public entering the council chamber are accepting that their images will be retained and broadcast by the council. So if there are any members of the public or press intending to record or film any part of today's meeting, please ensure this doesn't disturb the conduct of the meeting. And if you're visually recording, you're requested only to focus on recording. Thank you. So we're going to move into the agenda. Do we have any apologies for absence?
Sean Gibbons and Laura Bluff.
And to consider the extent, if any, to which the public and press are to be excluded from the meeting, and there are no issues on this agenda. Do we have any declarations of interest? No. So, public statements. I don't think we have any members of the public. No. And there are no items where the public and press may not be excluded. So before we move into the annual report, what we'll do first is we'll introduce ourselves, and then we'll move over to you guys, starting with Victor, and work our way around. So my name's Glynis Smith. I'm a ward councillor for Hatfield and the chair of this meeting.
Councillor Sue Knowles, Arnthorpe Ward.
I'm Councillor Ken Guest, I represent Rosington and Bawtry Ward.
Councillor Yetunde for Whitley Hill Intake Ward.
I'm Victor Joseph, consultant in public health, City of Doncaster Council.
I'm Min Boyak. I'm Infection Prevention and Control Nurse Consultant and Deputy Director of Infection Control at DBTH.
Sohail Bakhtar, Public Health Registrar.
Hello, I'm Rachel Leslie, Director of Public Health at City of Doncaster Council.
Hello, I'm Sarah Atkinson, Public Health Improvement Coordinator at City of Doncaster Council with a remit around sexual health.
Hello, I'm Sarah Smith. I'm from Public Health. I'm a Public Health Improvement Coordinator. My remit is suicide prevention.
Hi, I'm Rio Overton Bullard. I'm a Public Health Improvement Coordinator in Public Health at Doncaster Council with a remit around emergency planning and health protection.
Hello, my name is Julie Hogarth. I'm Screening and Immunisation Place Lead with the Public Health Programme team with NHS England.
Hi, I'm Cathy Wakefield. I'm Principal Screening Immunisation Manager for NHS England Public Health, and I lead the South Yorkshire Public Health team in NHS England.
Thank you, Chair. Am I okay to kickstart off? Okay. As an introduction, this is our 11th annual report to the Scrutiny panel. So we've been going for quite a while. Public health moved from the NHS to the council in formally April 2013. And when we settled a year into, we have been producing annual scrutiny report on health protection to this panel. You can see that by the nature of the health protection, it is quite diverse. It's quite, we have all colleagues here. They've been having key parts in the health protection agenda. It reflects what I'm going to do. So I'm going to give you a quick overview, and then we'll open up to the questions you've got. The key thing I want to highlight from here is the scope of health protection. We've been doing this, but it's worth reminding ourselves what does health protection entails. I'll highlight some brief overview around infection prevention control. I'll pick up something around MMR and pertussis. Vaccination is a key part of our vaccination program, and as well as some highlight on the screening program, sexual health. There are a few things also around suicide prevention, which I'll later touch on as well. So the scope of health protection is quite broad. So colleagues around the table are represented in a way, but it's worth kind of highlighting some of these key areas. We have got work around emergency preparedness, resilience, and response. We don't have to wait until we have emergencies such as we've got flooding or fire. We build that into element of the preparedness. Obviously, when incident happen, we have to respond to it. We have infection prevention control, traditional based in the hospital settings, but we were conscious pandemic has shown us that we need to strengthen our infection prevention control in the community. Things like care homes, for example. So that is the key part of it. So, and then we have tuberculosis. Many people remember it's a disease of long time ago, but it is still a problem. We are actively tackling the issue of TB in our community. Air quality is important. We work with our colleagues to address issues to do with air quality. Similarly, sexual health, a core part of what our mandate is. Substance misuse, suicide prevention, immunization, and screening. There may be a few other things that may not be there, but these are some of the key aspects of it. We had to work closely with our partners, for example, now the UK Health Security Agency, to help us with things like intelligence, surveillance, what is in the horizon, that kind of thing. I did talk about infection prevention control. We have learned lessons from the pandemic. We had service in place. It was small scale before pandemic. When pandemic came, it tested our resilience. And the system responded very well by all agencies working together to address the challenges. And after pandemic, we had to put in system that is resilience, and that has kind of continued. And you can see there, for example, the kind of proactive work in terms of our IPC nurse, and maybe Sia is going to kind of highlight some few things. But you can see, for example, more than 800 face-to-face visits in the past year. It's quite a lot of work. And that is really helpful because they are able to pick up problem early or respond to problem quickly. And you can see also education session with our care homes managers, people involved in looking after our older people in care homes. That is quite proactive work. We work very well as agencies, as partners, and that has been built over years of close working together. If there's anything, we could pick a phone and then reach each other. not only locally, even with our UK Health Security Agency colleagues as well. That has helped us quite a lot. Because of what we have done, it is cited as example of good practice by our other partners, including those within the sub-region here. I did say TB is a big issue. What happened during pandemic was we had focused mainly on COVID. Many cases that may have been TB had been either diagnosed very late and in an advanced stage. And some cases are very complex. Maybe one or two cases, but it will require several multi-agency meetings because they are the cases that do not have, either don't engage with services or they don't have recourse to public fund. We cannot simply wash our hands. We say, well, we can't do anything with you. From health protection point of view, we have to respond to those cases. So TB is still increasing, the rate is increasing. We have TB nurses in the community working with it alongside our hospital colleagues to manage those cases. And MMR, measles, mumps, and rubella, and pertussis vaccinations are important. We have noted over the years that our MMR vaccination is lower than what we would expect. So to put it in context, we need to have 95% of our people, children who needed to be vaccinated, to be covered in order to protect the 5% who haven't. If we have outbreak, that rate had been kind of below 90%, but we have put some effort to try to work on that in the past year or so. And that figure is now about 90%. We're working towards to get that to 95%. Now, to put it also into context, Doncaster is not exception. The figures for national level is also quite low. It's not reached that 95% yet. So this is something that you need to be aware of. It's a work in progress. We have a vaccination cell working on this. Breast screening is another important area. And the reason why I'm flagging this one is, again, uptake of screening. You can see there are 66%, 66.8% or 67%. We have our colleagues from NHS England would kind of highlight further. We have acceptable level of 70%, which means we are still lagging behind, but there is some work going on to try to work to improve that. That's what I want to kind of highlight, that there's some action plan to work on that, both include national work, but also local work that we're going to kind of tack onto that. Sexual health, again, we have a service in place. We do experience some cases of outbreak of things like syphilis, for example, that we are actively working on with multi-agency. We've just finished this afternoon a meeting with a multi-agency group managing the outbreak in Doncaster. It is a complex situation, and we're working on that to address it. But there are a range of other services as well in terms of preventative service, screening and to identify cases early. On substance misuse, for example, again, a lot of work is going on there. Again, from health protection point of view, it is to prevent infection passing from one person to the other, either because people share needle, that kind of thing. That we have pharmacies available that are working on that and ensuring also for those who use substance, the mechanism how to store it safely, so that other people who are not intended to take up those equipment substances use it. So there's a lot going on, again, as preventative measure to protect the health of our people who are in this client group of substance misuse. I think those are the key highlights I wanted to give you. I mean, the last one, sorry, is suicide prevention. Numbers is reducing, but put it in the context that we got about 30 cases last year. Again, that number may look small, but it's a big impact on families, friends, and people who know those people affected by suicide. A lot of work is going on in terms of training. A key thing to know there is working towards zero suicide in Doncaster. I'll pause there. I'm sure you have got some series of questions. Among us, my colleague, we will be happy to have that discussion on some of those questions. Thank you.
Thank you for that presentation. We do have some questions, as you would expect. So I'll read the titles first and then say whether we have any. So the first one, Emergency Preparedness, Resilience and Response. We haven't actually got any questions for that one. But on the second question, which is infection prevention and control, we have a number of questions, and we're going to start with Sue. Thanks.
Hello. What is the rationale behind the Gloves Off campaign, and what initiated this?
That's to me. The Gloves Off campaign started after a project in Great Ormond Street Hospital in 2018, and it was based on the recognition that we wear gloves far too often. We put them on too early and take them off too late, which means we don't wash our hands properly or more as frequent as we should be, or at the key moments. So what they did was have an awareness campaign, and that's kind of spread throughout the whole NHS now. So NHS England promote it, the Royal College of Nursing, and we try and do that every year along with other organisations to try and promote best practice in only putting gloves on when we need to, only at the point of care, rather than, because what we see is we put them on too early thinking I'm going to need them, and then we might walk past a person, somebody distracts you, and you end up picking something up and not washing your hands as you should do when you get to the patient or before you put gloves on. So that's what the whole premise of the campaign is, and that's what we try and promote. We do that in not just the awareness campaign during the year, but also we do that in it's normal educational subjects for us as infection control practitioners, is when you are to wear PPE, when you're to wash your hands and all that kind of stuff. So that's really what it's based on.
Thank you, I understand.
Thank you, Chair. So my question is around the Gloves Off campaign as well. I just want to know if there's been a link between the impacts of the Gloves Off campaign and the reduction in hospital-acquired infection.
It's really difficult to measure that because there's so many variables in reducing infections. So there's hand hygiene, there's other PPE, there's all the things that you would class as standard precautions. So that's cleanliness of equipment, cleanliness of the environment. And to pick one and actually prove that that's had an effect on infection rates is difficult to do because it's normal practice to put all those things in place. So I can't tell you that there's a link or that we can measure, or that it's purely down to glove use that infection rates have come down. I can't answer that for you. We would need to swab gloves and swab people and kind of associate it all together.
Right, thank you. I actually have two more questions, if I can just take these two together. So, is this done in collaboration with the change of other PPI, which you've partly answered, that you know everything has to be done together. So I just want to know if the hands-off is done in collaboration with change of PPI like apron, nose mask, and others from patient to patient. Also, has there been increase in hand washing as a result of Gloves Off? Because you've mentioned that one of the reasons is to encourage more and effective hand washing as well. So
I'm not sure I'm understanding your first question. Are you meaning in an episode of care, do we promote taking gloves off as well as, let's say I've finished helping a patient and we take the apron and the gloves off together, or is that
okay, so let me explain to you. When I saw the gloves off, without hearing your rationale, the first thing that came to my mind is reduction in hospital-acquired infection, because I know that one of the mistakes that get done most of the time is carrying infected gloves from one patient to another, touching inanimate objects like handrails, doorknobs and beds and case file and all, and thereby spreading infection. So, but because that's not the only vehicle, if you know what I mean, hand gloves is not the only vehicle. The gloves, the aprons, the face masks, and everything, they are also involved in the same scenario whereby you can move infection or pathogens from one place to another or one patient to another. So that's the reason I asked the question that, okay, so if you are doing gloves off, are you doing apron off as well? Are you removing aprons from patient to patient, from wards to wards? Are you removing face masks as well? Is it done in collaboration with other factors as well?
Yes, exactly for the reasons you've just said. So we have, as part of our educational campaigns, standard precautions, the points when you should remove your PPE, and yes, we do always promote that you put it on at the point of care. That includes your gloves, your apron and your mask if you need to, if you've got a mask on, and you do that at the point of care and you take it off when you've finished at the point of care, and then you wash your hands and you continue. That's part of normal practice and normal educational practice with infection control for the very reasons that you've mentioned.
Thank you, Rachel. Sorry, Chair. Rachel wants to speak. Is it?
So just for some of the context with that as well, so Doncaster is pretty unique in that it has a commissioned infection prevention control service that's funded by public health funds. We started this in COVID and we've chosen to retain it beyond COVID. And what that gives for us is a resource, but also some assurance. So we've got a small team, MIMS team, that are based in the hospital, work predominantly there, but will work across as well. So we've got a team of skilled infection prevention control nurses that can keep most up to date with the evidence, because the evidence changes here. We saw through COVID and beyond that we perhaps weren't using the PPE, the personal protective equipment, that we needed to in some situations, and in some situations we were using it more than we needed to. And there are environmental aspects of that, and things like gloves don't come for free either. So we've got a team that are dialed into national networks on what's the best infection prevention control practice, and they use their skills and knowledge both to advise when we've got outbreaks in our hospital and other settings, but also to get that training and knowledge into the wider staff base, so that the practice that they're using day to day and the normality of washing your hands and the right PPE equipment at the right time, we've got a team of staff that can do that and ensure that it's at the best level it can possibly be in our Doncaster settings.
Thank you, Rachel. Chair, I haven't got the answer to if there has been an increase in hand washing as a result of the gloves off. Thank you.
So we promote hand hygiene all the time anyway. So to say that it's more, you would hope so, because the idea is we're taking the gloves off so that you can wash your hands sooner. By definition, if we're wearing our gloves all around the wards, we're not going to wash our hands as we should do. So yes, there will be, as a result of the hand hygiene campaign promotion, for more hand washing. In terms of hand washing as well, both within the acute and in the care homes that we cover, we do assess the staff's hand hygiene competence as well. So we actually teach them how to wash their hands, and we assess on their technique, because it's not a kind of social hand wash, if you like, that for healthcare we always there's a specific technique, and we promote that in all the settings that we go to. In terms of hand hygiene compliance within the acute trust, where we measure it because we're more there on site all the time, our compliance is 96%. So 96% of the time when we're watching, hand hygiene is performed as it should be. But in terms of gloves off campaign, yeah, we would hope that if you're removing your gloves and not walking around with them, that hand hygiene would go up.
All right, thank you.
Thank you. You have answered some of my questions along the way. Do you have any other concerns regarding this campaign? And how are the impacts of this campaigning being monitored?
So I have no concerns in that. I think it's a really good campaign, but it also, not just from an infection control point of view, it's from plastic use as well and waste. So we'll be less throwing away less gloves and saving money as well. But I don't have any concerns for the campaign. And what was the other part of the question, please?
How are the impacts of this campaign being monitored?
So it's an awareness campaign. As I say, we audit hand hygiene anyway. We audit PPE use, so we measure that. So that's ongoing anyway, that's routine. So to say that as a result of the campaign, I can't give you, we had the campaign and then PPE use went down, because we're constantly doing that, and we see ebbs and flows with new members of staff come in, with new ways of working, and then that's why we're constantly educating all the time on the same things.
And do you have any figures around the success of this campaign?
No figures, just except for the hand hygiene compliance, as I gave, for 96%. As I say, we do PPE audits. We do them. There's no kind of regularity. We will do PPE audits if we think there might be an issue on a ward. If we've got an outbreak, we'll go and have a look at that and see what the practices are. But we don't say go around every ward and do a PPE audit every month, because we're not a big enough team to do that. But we do look at it, and usually compliance is good. There's always pockets of where that's why we're in a job. And like I say, with new staff coming and going, there's always that opportunity to teach and learn that.
Thank you, Chair. So this is about the COVID infection outbreak and the 2 norovirus infection outbreak between January 2024 and December 2024 on the medical ward at the DRI. Are these outbreaks related? Can you say that there is anything that triggers both of them, or you can link them together? Whether yes or no, are there any preventative steps in place to bring this figure down in future? Thank you.
So no, they're not linked. So they would need to be linked in time, place, and organism. These were not, so they were on different units. It's very difficult. I mean, the numbers are low compared to other organisations. Norovirus was particularly difficult for a lot of organisations this year. Preventative measures, all the things we do, so hand hygiene, PPE, it's all geared towards minimising the risk of infection passing from patient to patient, and that's what we see in outbreaks. Infection has gone from patient to patient. So that's difficult sometimes because there's so many variables. So, for example, if you've got a person whose immune system is really good and they're exposed to COVID or norovirus, they won't necessarily even be affected by that. And if they're not affected by that, they won't pass that on. Similarly, you can have the other extreme where you've got somebody whose immune system is not as good. They're then going to be affected by the disease, have the symptoms and pass it on. So it's really variable. So we've had cases of norovirus and COVID within our wards that haven't gone anywhere, haven't spread from person to person. We're doing the same things. And then we've had other, the ones that we mentioned, the COVID and norovirus, in wards where we have seen spread. And that can also be to do with the organism as well. So if you've got COVID, I could have COVID now and expose everybody here to it, but you won't know that for several days because of the incubation period, and that happens in hospital as well. So by the time you can't see COVID or norovirus, so you don't know when there's no kind of puff of green smoke, much that we would like there to be when exposure or contamination occurs. So you just have to then see the symptoms a week down the line or something, and then unfortunately by then patients have been exposed. So they're very difficult. These organisms spread norovirus, for example, if you've got a size of a pea, vegetable pea, full of norovirus particles, is enough to infect everybody on the globe. It's that infectious, whereas others are not so infectious. So it depends on the organism as well and how that behaves within the body as well. That affects our outbreaks, but it would be great if I could tell you next year we're not going to have any, but I can't.
Thank you. I did ask if there were steps that that are in place.
Yeah, so as I said, those are all the measures that we talk about. So that's the cleanliness of equipment, cleanliness of hands, cleanliness of patient equipment, the wearing of PPE, hand hygiene, all those kind of things. In addition, we have put doors on all of our bays in the hospitals so that we can compartmentalise. So if you've got a bay that's affected, you can close the doors on those bays and you've got a physical barrier and hope that it won't go to the next bay. So all of those kind of environmental things and practices are all the things that we do to prevent infection from spreading and outbreaks from occurring. But for the reasons I've also mentioned, it's really difficult sometimes.
Thank you.
Can I just make sure that everybody's laptop's on mute, please? So the next questions are on air quality. So I'm very aware of the monitoring, particularly around the city centre. And my children are now adults, but we remember cars and traffic around our shopping centre. And now as a grandparent, I'm very conscious that I don't have to think about cars in the middle of town. And that's, for me is very reassuring. Would public health ever consider the case of reopening our town centre to lots of cars? And obviously about the health and safety risks that would create.
Yeah, I'll answer that one. So on air quality management areas, we've got 8 in Doncaster, interestingly labelled 1 to 7B. And the one that covers the town centre doesn't cover the whole town centre. It covers a patch along the A630, otherwise known as Church Way. So that's the air quality monitoring area that covers the town centre. We're required to write up and agree an action plan that covers those areas each year and submit that to DEFRA, and in that it describes a number of measures, so whether it's more environmentally friendly council fleet, or whether it's the presence of our walking, wheeling and cycling strategy that we have for the borough. More techie complex things like road vents might be the right thing for some areas, or work around cleaner taxis. So a number of different measures that can be put in place around those areas of poorer air quality. Your question about public health considering a case, so public health wouldn't be a decision maker on any proposal like that, but the role of public health is to provide both advice and evidence, and we would take that in the way that we do around how all council decisions are made. So what we do is we provide health implications on every corporate report that comes through to political decision making, and we provide in that health implications section the context of any health and wellbeing impacts on any proposal made for that political consideration in decision making.
Thank you for that. next questions are around sexual health, and I think that's Tunde.
Thank you, Chair. So this is around the home testing kits that are available to order online for chlamydia, gonorrhea, syphilis, and HIV. It's all around the quality of the performance of the test kit. So is there any support offered in keeping the home test kit at optimum condition, just to ensure effective testing results? And then the second question is how results are managed. So like the confirmation of the positive result and follow-up of treatment and testing of sexual partners, just to make sure that reinfection is not taking place over and over again. Thank you.
Yeah, so I'll answer that as well. And I've got Sarah next to me who will correct anything or give any updates on what I'm answering. So on your two questions, so home testing kits for STIs aren't particularly new. So we've had home testing kits available for different STIs for quite some time. We find that uptake is good, the convenience, but also not having to go along to an appointment. You've asked about keeping them in optimum condition. So we contract, so it's a contract with the provider of the test kit, and in that test kit has got full instructions about how to use the test kit, but also how to store it and how to return your test sample as well in this best quality. Just to note, for any testing for an infection that happens, there is a degree of both sensitivity and specificity. So no test that's available is 100% sensitive and 100% specific, and by that I mean ability to tell whether a disease, an infection exists or not, but also how specific it is, so whether it's a particular type of infection. So any test that exists doesn't have 100% specificity and sensitivity. So just to describe that as well, and the different tests will have different levels, which will be described by clinicians that are using them. Just on what happens when somebody receives their results, and I'll get Sarah to talk through a kind of scenario with that as well. So anybody that tests positive, there'll be a notification to the patient, but also to the Sexual Health Service, which is located in the city centre of Doncaster, and we've got active contact tracing as part of that. So they will actively speak to the person that's tested positive. They will go through the sexual history of that person to identify who else might have possibly been exposed to the same infection. They will take the details and they will try really hard to make contact with that person and encourage them to come along for testing as well. So that's the process of being able to identify other people who might have been infected with the same infection. I'm just going to check with Sarah. She might want to add some details about the process.
No, I think Rachel's summed that up ideally there for us. I think just to reiterate that the home testing kits, they go off to the lab who manages that for us, so that's Preventex. But as Rachel says, once there is a positive result from that, it goes into our normal sexual health services pathway. So our sexual health service clinicians deal with it from then on, not Preventex.
Thank you.
Yeah.
Thank you. Within the testing kits, and obviously they are, with all the information, they are well taken care of. Do we keep a number of the false positives from the testing kits?
So you wouldn't necessarily know whether it's a false negative or a false positive just by nature of it. What might happen in some cases, so some tests will require blood, so a finger prick test. And in some of those situations, so for the bloodborne, so for HIV testing and hepatitis B testing, yeah, I've got that right, hepatitis C testing, will be a finger prick test. And on some occasions, somebody doing that at home might not get the amount of blood that's needed to be able to effectively do that test. If that comes back to the lab and they're not able to process that test because of the quality, they'll get in touch and they'll send another one out. But in terms of false positives, false negatives, for any situation, you have to draw it out in a graph. You'll expect a certain, usually small percentage to be a false positive or a false negative. So screening will never answer every single question about whether there's a presence of an illness or not, and that's why we might rely on things like symptoms as well, so diagnostic as well as screening.
So when we had our meeting, we didn't actually have any questions on substance misuse. Does anybody have any now? I'll just check before we move on. I just wanted to say I felt it was really positive to see the naloxone training up there. That's really, really positive. So moving on to suicide prevention, it's Linda first.
Thank you very much. Regarding data, could you provide me with a quick overview of the current picture and what concerns are there for the future and what campaigns are in the pipeline?
So for the last 3 years, we've had a steady decrease in our number of suspected suicides across Doncaster. Men are still 3 times more likely to die by suicide. What we have noticed that while we have had a decrease in men, with the numbers decreasing, there has been the numbers of women has remained the same. So if we were to have one concern, it would be that the number of women deaths would rise. So previously we had a big campaign called Let's Talk, and it was targeting men. That was around for a few years, and we would reuse that. But unfortunately, because of GDPR, there were living individuals in the campaign video. We've had to stop using that because we would not been able to get in touch with everybody that's in the video to ask for permission to continue to further use it. But that said, the video, whilst it was great, and we had millions of views from right around the world for that video and that campaign, it wasn't very friendly for using on social media. So what we've decided to do this year is create some short animated clips that we can reuse throughout key dates in the year to target people, for example, at social isolation, involved in domestic abuse, so those people that are at risk of suicide.
Okay. So I've actually done the suicide awareness training. And I found it a really good experience and very positive. So I wanted to ask, is the awareness training still taking place? Who it's made available to? What the take-up is? And what the future plans are for that training?
Thank you. So, as you know, we've had the Zero Suicide Alliance training around for a couple of years now. This is where we go into the community and invite people to come along and do the training. It's very basic, simple confidence skills around asking questions and maybe spotting signs that somebody is struggling with their mental health. Going on from the success of that, we've got a really large programme of training this year, with over 450 free places in Doncaster. There are 3 different types of training. It's all around suicide awareness and suicide prevention. And what we've done is we've targeted people who live in Doncaster, who volunteer in Doncaster and the volunteering faith sector for the training. It's online. We've got a combination of online and face-to-face training sessions that will teach people the basic skills and give them confidence to either spot signs, have a conversation, and support that person to seek support. So there's around 450 places on the basic training. We have planned training that's going to be delivered in Urdu as well. That will probably around April, May, so we're just setting the dates for that. We've got 20 places around some specialist suicide awareness training for the LGBT plus training. That will be targeting frontline workers. So the previous 450 places, that they're for residents or volunteers, but the LGBTQ is for frontline. And also as well, we have over 200 places right across South Yorkshire for preventing suicides in adult social care. It's a 3-day programme that we've developed. Public health leads across South Yorkshire, we've come together and developed this training. It has already been delivered via online. Majority of attendees were from Sheffield. We did have a few from Doncaster. And that's the reason why we're rolling it out again, and targeting and raising awareness more in Doncaster. So hopefully that's, my calculations, over probably around 500, 600 places throughout the year, free training.
Your suicide awareness training, do you take this into high schools for the sixth formers?
No, it's not been developed for 18 years and below.
So Sarah's described there what's called citizen training. So it's available for anybody resident in Doncaster, available online, and also available in various community venues as well. When you talk about people who are at risk of suicide, we're able to describe who those categories are, but particularly people who have been bereaved by suicide as well are at increased risk of suicide themselves. So resources for children and young people. I don't know, so if you want to talk about the resource that was developed for children by Chili Pep as well. So we do have separate focused resources for children and young people.
Yeah, so this was a resource that was developed by bereaved children and young people. It's a toolkit that's we commissioned an organisation called Chili Pep in Sheffield to develop it along with the children. It was award-winning at the Local Government Awards last year, and we've just had a new release of an easy read version. It is a toolkit that an adult can use to work with a child, or the child or young person can use themselves. It's got ideas around how to communicate that their loved one has died by suicide, also some how to communicate how they're feeling, and things to continue their support throughout their bereavement.
Right, so the next one are immunisation and screening programmes, and the first question's from Sue.
Regarding the age limit for the screening programme, could you provide clarification on why it appears to go up to 64 for cervical screening and 70 for breast screening? I mean, why it only goes up to that age? Thank you.
Oh, yeah. So, do you mind if I come in first? Now, we've got our screening immunisation leads, but I particularly enjoy these questions because it allows me to dig into my brains and memory of the things that I've learned, and then glance across over to my specialist colleagues who can correct me if I get anything wrong. But I just thought that it would be helpful to just describe, again, screening and the reason for screening. So screening by definition is looking for the presence of an illness, of a condition within an asymptomatic population. Screening programmes, so we've got 3 cancer screening programmes. We've got breast screening, we've got cervical screening, and then bowel cancer screening as well, which is your test kits that come through into your household. The act of screening itself has potential to cause harm in different ways, and screening programmes are approved by a national screening committee based on a set of nationally set conditions. So just to use the description about, so when you're deciding whether to have a screening programme or not, we have to be ensured that the benefit gained by the individuals using that screening programme should outweigh any harms, which can be things like overdiagnosis, overtreatment, false positives, false reassurance, and general concern. So just to give that context around. Now, your questions around why different age groups, I'm going to glance just nervously across to my specialist colleagues as well. So why for cervical cancer a different age to breast screening? So it looks at the evidence of when that cancer is most likely to happen in an age group, so both by age and by gender, and that is different for cervical cancer and it is different for breast cancer. So for breast cancer, it's screening every 3 years between the ages of 50 and 71, and then cervical screening starts at age 25 and goes through to age 64, and the intervals are different, so a bit more regular, a bit less regular. So hopefully that will give you some of that background as to why we look, or we put a screening programme is set nationally by the population group that's most at risk. And I'm going to check with my screening colleagues if I've got that right.
Thanks, Rachel. Yeah, absolutely. It's all evidence-based. So whenever the the UK National Screening Committee are looking at a screening programme, whether it's cancer, young people, antenatal, newborn, etc. They will look at all of that evidence in terms of the prevalence of the disease. So how likely is that disease to occur in different age groups? There's got to be a benefit from, it's got to be treatable. There's got to be a benefit from receiving that treatment. And again, part of that evidence is the benefit at different of interventions at different ages. So yeah, again, bowel is different again. So and again, it's constantly reviewed. So if you look at bowel screening, for example, we've just gone through age extension for bowel screening. So again, as new evidence comes on board or as disease prevalence changes, they will constantly review it to see if there is an added benefit of extending that screening to different age groups, whether that be younger age groups or older age groups. But then usually within most screening programmes there's an option that once it's finished you could opt in if you wanted to, if you've got concerns. But again, it's generally the fact that for cervical, partly down to sexual activity, rightly or wrongly, but that's part of the evidence in terms of that the risk that poses to an older population being lower.
What about the breast? Sorry, what about the breast screening? I can see the cervical one, yeah. What about the breast screening?
Again, it's looking at the evidence and how likely breast cancer is likely to occur beyond that age. But again, there is that option to opt in if people if women want to. But again, it's all based on that evidence that the majority of cancers will occur between those ages.
Okay, thank you.
And never missing a chance for a public health message. So if you do have any concerns, if anybody has any concerns about changes to their body, whether it's the presence of a breast lump or a change in a breast or any other symptoms that they can be concerned about, they don't have to, they shouldn't wait for screening. That is then a diagnostic. So go to your GP, describe your concern, and that's a diagnostic test. That's not a screening test, which is they're looking for a presence in an asymptomatic population. So yeah, never missing a chance to get a public health message in.
Thank you very much, Chair. Can I ask, Chair, if I can ask both of my questions together? Because thank you very much, they're all related to breast screening. Yeah, in terms of breast screening for men, I do know that breast cancer is not restricted only to women, it occurs in men as well. So what is taking place in terms of screening? Do they get screened at all? If they do, what's the criteria for screening them?
Yes, so again, they will look at the evidence across all populations. A lot of it, I think, is down to hormones that females have that increase that risk in terms of breast tissue. For males, if a female has transitioned, a male's transitioned to female, there is always that option there, and they've still got residual breast tissue. They can, again, be referred into for breast screening through their GP. But again, for some of the screening programmes, the risk is more prevalent in certain genders, and that's, again, it's that kind of cost-benefit analysis, and as Rachel said, kind of the benefit to the individual. So that's why men are not included routinely in breast screening. Similarly, females are not included in AAA screening because the degree of risk isn't deemed to be the same for a variety of reasons. But I think with breast screening, it's a lot of it's down to hormonal impact.
Thank you. So if a male now has a relative, maybe a mother that had breast cancer, and they got to a certain stage in their life, there's nothing, to screen them, to prepare them for the future or to assess their states?
Not through the breast screening programme, no. So obviously with females that have got a familial breast cancer, then there's the very high risk pathway, but it is only for females at the moment. So again, as Rachel said about the symptomatic pathway, it would be a conversation with the GP to look at other routes, but it's not, males are not part of a routine breast screening programme, even through the very high risk pathway.
Will it be something to be considered in future, even if it's just cancer markers test, even if it's not just breast screening, like hormones testing, markers testing, just to check? Because
I don't know. I can't answer that because I don't make those decisions. Again, that goes through UK National Screening Committee. So the way that works is if any organisation or any party feel that there is a potential case for screening for any condition, then they would present that to UK National Screening Committee. They would review all of that evidence, they would debate all of that evidence, and then they would make a judgment as to whether it's a definite yes, whether it's a definite no, whether it's a no at this point in time, but we'll review it again when further evidence comes to light. So I wouldn't say that it would never be an option, but obviously that's a national decision for any changes or any new existing programmes or any new programmes.
Thank you very much. Can I ask my second question? Oh, you want to say something, Richard? Okay.
Sorry, I can't help myself. So yeah, probably a version of some of the answers that we've already been given. So just for scale, there's around 400 men that are diagnosed with breast cancer each year. So not insignificant, but certainly much, much smaller than the 50,000 women that are diagnosed with breast cancer each year. So that bit that I talked about earlier, that no screening programme is without harm, and listed what all of those elements were. So things like being able to detect cancer markers in blood are still, I think, relatively early, and probably hasn't got the case to make to the National Screening Committee that there can be a specific enough blood-related test that would be able to identify that. So that's why we've not got a national mandate from the National Screening Committee for additional breast cancer screening programmes for men or for different age groups. But again, if you are a man that is concerned with a change in your breast or chest tissue, then again, go along. That's a diagnostic that you're asking for, not a screening programme. Thanks.
Thank you, Rachel. So now going to my second question. Oh, sorry.
Yeah, just wanted to add to that point. What has been said, there are several criteria for instituting screening program. One of them is that the condition has to be a public health problem. And the point you raised there, when it is very rare, particularly among men, in terms of, and you put it against the other criteria, it doesn't warrant a screening program to be instituted for that reason. That is why in itself, there's no specific program targeting men for breast cancer. Evidence still will continue to be monitored and reviewed, and in the future, appropriately, decision can be made. So the reason why it is not is because of in terms of the criteria, including the problem, the public health problem it poses, doesn't warrant putting screening program in place. Thank you.
Thank you very much. My second question is regarding the invitation, timely invitation in line with the test due date for breast cancer screening. So, can there be specifics about the timing of the invitation for the fixed appointment? Also, I read in the report that you get invited when you are 50, and I turned 50 last year. I haven't got any invite up to now, so I don't know what is the criteria. Well, how does the timing works? Do I need to wait till my next birthday, or well, how does this work?
Yeah, I'll hand over to Julie in a minute to explain how it works. But again, it's just to reiterate that every screening programme works differently. So again, with bowel screening, for example, it's based actually on your birthday. So with it, generally within a couple of weeks of your ex-birthday, you will receive a bowel screening kit. The other programmes don't work in the same way. So I'll let Julie explain how it works for breast screening.
So just to say that in line with the service specification programmes are required to ensure all service users are invited to attend for their initial, that's a prevalent screen between their 50th and 53rd birthday, which, as Kathy says, differs a little from other screening programmes. There's a cycle of invites rather than on the actual date of birthdays.
Just to say as well, we are working with all of our providers. There's been a slight change to bring that appointment down as near to 50th birthday as possible. So at the moment it's between 50 and 53, but we are working with all of our providers across South Yorkshire to bring that down and get that invite closer to that 50th birthday. But it doesn't, if you've not received it already, it doesn't mean that you've not been invited or that you won't be invited. It's just the way that programme works in terms of that cycle of invites. We used to refer to it as round length. So it was kind of, it worked on kind of GP by GP by GP. That's changed slightly as well, but you will be invited. It's just not based on immediately that you hit your 50th birthday.
Right, thank you. I'm just thinking that, well, in the report, the range wasn't written to say 50 to 53. Having said that, I'm thinking that 3 years is a big gap. It could be a matter of life and death between 3 years, and I don't know whether this was risk assessed. So if invitation is going to go out to a certain group of people and the age range is, the gap is 3 years, to me, it's significant. It's not 6 months. It's not a year. It's a matter of anything could happen between 3 years.
So again, it's a UK NSC National Screening Committee decision as to how frequently screening should take place, again based on disease prevalence, risks, resource, etc. So they deem that within that 3 years, as long as that screen happens every 3 years, then the risk is kept at as low a level as possible. As Rachel said, no screening test is foolproof. It's never 100%. But the risk of between kind of 50 and 53, whether you attend that within the first 6 months or the first 18 months, UK NSC wouldn't class that as negligible. So as long as you attend within that first that 50 to 53 year period, then there's not deemed to be a significantly increased risk. So going at 50 and 9 months as opposed to 51 wouldn't be deemed significant in terms of risk.
I thought my understanding of your first explanation was that the screening is done within the 3 years, not that the cycle, like you do it every 3 years. That wasn't my understanding of your first explanation. So now I'm thinking that I'm getting a bit confused now, because what you've now said is that it has, so long you do it within the 3 years, in 3 years' time, just like cervical screening, when you start it's 3 years and then we get to a certain age, then it's in 5 years' time. That I understand, that if you are negative, like this year, 3 years' time, the gap is okay for it to be repeated. But if the starting period is within 50, and it's not 6 months after, it's not 9 months after, it's like you wait 3 years before you had your first screening. That's what I'm saying. What risk assessment was done on that?
So I can't tell you what research has been done because I don't review the evidence. Again, that all goes through a national committee. But yes, the screening happens between 50 and 53. And then if that's negative, then again between 54 and 57. So you will continue on that 3-yearly cycle. So if you are screened at 50, then yes, you'd come in at 54. So there is that ongoing regular cycle, regardless of when that first screen is. So as long as you are screened within that first 3-year period, then that will continue at that 3-yearly interval.
Chair. Do want to say something?
Part of the evidence in determining the frequency of the screening program would have looked at calling individuals at various time frame. It could be every year or every 2 years, or even 4 years or 5 years. Now, the evidence there will say what is the optimum time for this particular condition that we need to set the frequency. It will also balance that again, individuals, impact on the individuals, because if you call people frequently than they need to, the inconvenience to them. It also balance again resources required. So that is the rationale in terms of the time frame. The caveat in between is if an individual's experiencing symptom, they can always present. So they can, if they've got any symptom, they can be seen. If there's anything happen before their next screening. So just to give you the rationale why the recall is every 3 years, and why not every 6 months or every 9 months, as you were saying. It's because of that. They've looked at the optimum time when they can call people. It doesn't mean that it may not miss some people, but that is the optimum time based on the evidence to be able to have the next cycle. Thank you.
Thank you, Chair.
My next question, I'm actually not going to ask because you answered that one, Victor, during your presentation. So my next question is, it's really positive that DBHFT provides staff support for cervical screening. Is this across both trusts? And I also wanted to just give a shout out because, you know, very proud to have seen the health van all over Doncaster with the cervical screening service. Many of us sitting here, I know, have shared that over and over again so that as many people as possible can see it. And I wondered what advertising or how it's done really, apart from Facebook.
Sorry, stepping on your toes again. So I can answer the second part of that, and I wonder if Victor or someone else can answer the support for staff at the hospital. So the health van has been a result of some additional women's health funding that we had into Doncaster that we've deployed in various ways, and this has been one of them. You've asked about how we've promoted it. So we've done something a little bit different this time. That the young people will know more about. So we've got a member of the Well Doncaster team who's in a communications, community engagement type role, and those that have been using the service or approaching the service, she's been doing short clips with them and using those to again promote, give ease, give confidence to people that might want to have their first or a subsequent smear a van. But yeah, we've used all the normal social media, and thank you for retweeting, re-promoting those. There's been a lot of word of mouth and actually just the opportunistic. So seeing a van and seeing what it's all about is usually quite successful as well. But yeah, the thing that we've probably done differently is having the kind of TikTok type videos of people that have had their screen on the van and sharing the experience that they've had from that. And that's been thanks to our younger demographic of Well Doncaster team member helping with that.
Just is the cervical screening available to our other health trust, really.
It is, yes.
My last question is about avoidable repeats of blood spot tests. And whilst I know we're not unique in Doncaster, that in some ways doesn't make me feel any more comfortable. This is an area I have some personal experience of as a learning disability nurse. So I take on board the improvement, but obviously that needs to continue. Are we at the same level of meeting the standards as others in South Yorkshire? And the reason I ask that is that I attend the regional scrutiny and like to be up there with the best figures. Thank you.
So Doncaster's not an outlier in the region at all with the blood screening, and the work focused on maintaining the improvement that we've seen continues to ensure that that delivery is sustainable.
I just wanted to finish by saying I'm sure others saw our Director of Public Health on the news the other night talking about breast screening. Thanks, Rachel. It was a wonderful debut, if it was your debut, as Director of Public Health. What I need to say now is that we note the achievements and challenges and mitigations across the breadth of health protection in 24-25 and the priorities and work planned for the forthcoming year. And we also note overall assurance on health protection for the people of Doncaster. Can I ask, does the panel agree? Okay. So I'd just like to thank you all for your time this afternoon and for answering our questions with the patience and forbearance that you have. We're actually going to look at our work plan now. So I'd like to give you the opportunity to leave at this point. And thank you very much.
Okay, so it's the, sorry everyone. Okay, it's the work plan and forward plan update. That's at the end of the agenda. No, we're still at the formal bit. Yeah. As you know, it's always, you've got an up-to-date work plan in the back, but this is actually the last meeting of the municipal year, so there's not much to report going forward. Also in the report, there's the forward plan, but there's also not a lot at this stage about forward plan decisions. The one that's there is a future finance and performance report, which always reminds me, thank you, that basically if you have anything you'd like to feed into next week's OSMC, they're looking at Q3, just to let the chair and myself know, and I was happy to feed that in to the chair of OSMC. And unless there's anything you want to say at this stage, Chair, about this year's work plan, or we can close the meeting then.
I think we can close the meeting now. I mean, I think it would be really relevant to have an update from Sober Social and Drug and Alcohol Services at some point, but yes.
Thank you.
Yeah.
Right, so what I'll do now, I'll note them for next year's work plan and I'll close.